As the oral and maxillofacial surgeon's skill in temporomandibular joint arthroscopy becomes greater, certain limitations will be found to the traditional infralateral and anterior lateral approaches to the TM joint. This is especially true if visualization of the lateral trough and anterior lateral joint space or instrumentation access for the medial and lateral trough is required. Clear visualization of these areas is difficult with the current 15-degree angled scopes and lateral portals. To solve this visualization and access problem, a third entry portal is described, which provides for clear visualization and uncluttered instrumentation for the medial and especially the lateral TM joint spaces. This portal is the Endaural portal. The subject of this videotape will be to demonstrate the placement and working advantages of this approach. The Endaural approach is indicated whenever clinical diagnosis would lead to the conclusion that a lateral synovial prolapse, plica, or adhesive capsulitis are present. Often these conditions are difficult to detect on MRI or arthrogram. Direct visualization may be the only way to confirm and treat the pathology. Also, the Endaural approach allows better access to the medial trough for the retrieval of loose bodies and broken instruments, as well as providing direct angulation for the instrumentation of medial and lateral structures if needed. After placement of the ear packs, the TMJ is palpated and the initial infusion is accomplished with a 10 cc syringe of iced heparinized lactated ringer solution. The concentration of 2,000 units of heparin per liter of fluid will help to prevent blood clotting in the joint, which would otherwise block visualization. A back pressure or hydraulic action will be clearly felt as the joint is completely distended. Remember to angle the needle at 45 degrees anteriorly, superiorly, and medially. This will aim it at the posterior slope of the articular eminence and away from critical structures. The outflow needle and tubing are now placed anterior laterally. Immediate outflow through the tubing is confirmation that the inflow and outflow portals are in the same joint compartment. Be sure the tip of the outflow tubing is held up off of the bottom of the basin, flush until the drainage is clear. The 15-degree arthroscopic cannula is now placed at the infralateral portal. Continuous distension of the superior joint space is accomplished by connecting a 60 cc syringe to the outflow tubing temporarily to provide constant pressure. After puncture, drainage from the scope cannula confirms that it has entered the TM joint space. At this point, inflow tubing is attached to the infralateral cannula. This is flushed free of bubbles while the camera and arthroscope are inserted. The syringe is removed from the outflow tubing and inflow is established through the infralaterally placed scope. This directs the fluid away from the end of the arthroscope and helps keep the visualization clear. Outflow is reestablished through the anterior lateral needle and is confirmed at the outflow basin. To establish the Endaural portal, we first transilluminate the posterior wall of the joint as a guide to the position of the Endaural puncture. The anterior lateral outflow needle is removed at this point, and the joint distension is accomplished through the infralaterally positioned arthroscopic sheath. Guarding the tip with a finger, the 30-degree cannula and trocar are introduced into the joint space at the brightest portion of the transilluminated spot. Viewing through the infralaterally placed arthroscope, you will see the cannula and trocar enter the joint through the posterior wall. Removing the trocar from the cannula should produce a backflow of irrigation. Flush to eliminate blood clots and other debris. The inflow tubing is now moved from the infralateral cannula to the endaurally placed cannula. The outflow tubing is removed from the needle and is attached to the infralaterally placed cannula. The scope cannula will now act as the outflow channel. The 15-degree arthroscope is removed from the camera, and a 30-degree arthroscope is put in its place. The 30-degree angled arthroscope allows visualization in the medial and lateral troughs that is not possible with the standard 15-degree scope. By rotating the scope and holding a fixed camera position, a panoramic sweep of the joint from medial to lateral can be accomplished with very little lateral motion of the scope tip. Before reintroducing the 30-degree arthroscope into the joint is flushed clear. Initially, on endaural puncture, the posterior bilaminar zone and oblique protuberance can be readily visualized. Note how the medial trough visualization and access is facilitated. With the 30-degree scope introduced into the endaural portal, a rubber cap is inserted in the infralateral cannula to act as a seal around instruments. The infralateral cannula is closed with the thumb, and outflow through the infralateral cannula is confirmed. It is important to confirm the through-and-through lavage every time you change portals to prevent extravasation of fluid. Here we can see a left temporomandibular joint with a 30-degree arthroscope inserted into the endaural portal. We can visualize the lateral trough with its adhesive capsulitis present, with a vascularized synovial proliferation attaching with adhesions to the disc and articular eminence. This is described as a lateral capsular prolapse or impingement syndrome. An 18-gauge needle is used to dissect and free the adhesions from the articular disc as visualized in this videotape. Many times these are tenacious bands of adhesions. The proliferative synovitis can be readily visualized by the vascular markings and relative maturation of the adhesions. In this right endaural view from a different patient, one can see the right lateral trough with a proliferative villonodular synovitis. Note the vascular channels running up through each of the synovial villi. The infralateral cannula can now be used to insert instruments into the joint. Here we can see a small cartilaginous fragment being pressed between the articular surface of the eminence and disc. A grasper forceps is utilized to retrieve the small fragment from the articular surfaces. Having an assistant stabilize the instrument cannula while working will steady the instrument in the joint and prevent exaggerated motions. From an endaural view, with the 30-degree arthroscope, a blunt trocar can be seen inserted into a right temporomandibular joint from an infralateral approach. The blunt obturator is utilized as a dissector to free up the lateral synovial trough. This is performing a lateral capsular stretch maneuver in order to free up the restriction of the lateral capsular impingement. The blunt probe is rubbing along the lateral surface of the articular tubercle at this point and is seen freeing up the lateral capsule from its structure. To expedite changing the 15-degree to a 30-degree scope cannula in the infralateral portal, a switching stick is inserted and the 15-degree cannula pulled out over the switching stick. The 30-degree cannula can now be placed over the switching stick and guided into the joint. This prevents continual trauma to the capsule and the joint as various arthroscopic cannulas are interchanged. Inflow is moved from the endaural scope cannula to the infralateral cannula. The 30-degree scope can now be moved to the infralateral portal, and the endaural scope cannula can be capped with a rubber stopper and used as an instrument portal. Remember to attach the outflow tube to the endaural cannula and reconfirm through and through lavage. With outflow closed off, the joint is distended, and a third 30-degree cannula can be introduced into the anterior lateral joint space. With constant distension provided by irrigating through the arthroscopic cannula, the third 30-degree cannula and trocar can be inserted into the anterior lateral joint space. This should be directed along the anterior slope of the articular eminence. As with the placement of the other cannulas, proper entry into the joint space is again confirmed by the irrigation backflow when the trocar is removed. The anterior lateral portal may be used for arthroscopic visualization or the introduction of instruments. Sealing the anterior lateral cannula with a rubber cap allows for control of fluid backflow during instrumentation. In this case, a small cup forceps is introduced to remove synovial adhesions and granulation tissue. Here we can see the reactive granulomatous tissue in a previously operated joint with reactive and proliferative synovitis. The cupped basket forceps can be seen removing tissues from this superior joint compartment for debridement and histopathologic examination. With the arthroscope moved to the anterior lateral portal, instruments can be inserted through the infralateral cannula. In this case, a blunt, hooked probe is used to test the tenacity of broad adhesive bands in this severely restricted superior joint compartment. One can see the relative amount of vascular markings apparent in these broad bands. Here, the adhesions are being wiped away from the articular eminence with a pulling and stroking motion of the probe. Due to their adherence, it was felt that a pull knife would be better utilized. Here, you can see this being used for the lysing of the adhesions. Utilization of the Endaural approach extends our surgical options. With cannulas placed endaurally, infralaterally, and anterolaterally, virtually all areas of the TM joint can be visualized and reached with instruments. And with care and sufficient dilation of the operating portals, instrumentation may be inserted directly into the joint percutaneously. This approach is restricted to the infralateral and anterolateral portals. The cartilaginous posterior wall of the joint is too rigid to permit direct insertion of instruments endaurally without the use of a protective cannula. Care must always be taken not to denude the meatal cartilage, which may subsequently result in otitis externa. In these examples, a cup forceps and a power debrider are shown being inserted percutaneously through the infralateral portals. The power debrider is particularly useful in removing fibrillated tissues rapidly. Here, we can see the microdebrider using a full radius cutter to help shave the fibrillated and degenerative cartilage from the articular surfaces exhibiting chondromalacia. To help control the suction power of the debrider, a small, self-contained suction unit is utilized. This prevents the excessive wall suction from evacuating the TM joint during the debridement process. At the conclusion of surgery, the external auditory canal is carefully examined with an otoscope for foreign matter or iatrogenic damage to the tympanic membrane. And placement of the external Band-Aid dressing.